Great. Welcome back to the House Healthcare Committee. It is still Thursday, March 16th. And we are switching gears now. We're going to hear about H414, which is an act relating to establishing an unused drug repository for Vermont. And how this is coming to us is from Dane, who is in the Representative Dane Whitman from House Human Services, but with the support of the policy team that we created between Human Services and Healthcare. So if you remember, we have Leslie and Mari and Dane and Noah from Human Services, and they feel this is important for us to put forward. So we're going to take some testimony. There's a bill, if we have time, we'll walk through. And then there also is a report that we will make sure gets sent out to everyone on this topic. So with that, I'm going to turn it over to Brendan Atwood, who's Public Health Policy Advisor for the Department of Health. So welcome.
Thank you, Madam Chair, and good morning, committee members. For the record, my name is Brendan Atwood. I am a Policy Advisor at the Department of Health. Pleased to be joining you today to discuss the Unused Drug Repository Program. I think if it'd be helpful, just give a very quick overview of how an Unused Drug Repository Program works, and then happy to answer any questions that you may have. The main purpose of an unused drug repository program is to get medication into the hands of the people who need it. The way this is done is that medication that is unused and would otherwise be discarded is collected from both institutions and individuals and distributed back to people who either cannot afford that medication or who struggle to afford that medication. Specifically, a program will work with institutions like long-term care facilities, hospitals, as well as individuals in some cases, to collect their unused medication. That medicine is then sent to a warehouse where a pharmacist inspects it for safety to make sure it hasn't been tampered with, that it hasn't expired, and that it's not a controlled substance. And then patients access that medication by working with a participating provider or a participating pharmacy. In our outreach in drafting this report that we provided to the legislature earlier this year, there is a broad consensus among stakeholders in support of establishing an unused drug repository program here in Vermont. And that's in light of the potentially significant health, economic, and environmental benefits associated with these programs. In terms of health, we would expect thousands of Vermonters to gain access to medication that, again, they either can't afford or they struggle to afford, which of course would have positive impacts on their health and their quality of life. The economic benefits fall into a few buckets. First, we would expect millions of dollars of medication to be saved and distributed back to people who need it. Nationally, unused drug repository programs have seen return on investments in the range of 8 to 1. And in speaking with some providers of these programs nationally, we had projections of about $3.5 to $7 million annually for Vermont. And it's important to note that that figure only represents the value of the medication itself and not the economic benefits that might accrue from having healthier Vermonters participating in the workforce and having a higher quality of life. The environmental and then an additional economic benefit is that institutions are currently paying to have this medication discarded, and they would see some cost savings there as well. The environmental benefits are derived from the fact that all of this medicine would be likely measured in tons, by the way, would be diverted from the waste stream. Turning to the bill, the department is supportive of the language here in the bill that provides the Agency of Human Services with the authority to contract for and regulate the work of an unused drug repository program. Ideally, we would find a nonprofit organization that is already administering such a program to work with, that has the infrastructure in place to do so. And the reasoning for that is twofold. First, it would save on administrative costs for things like a warehouse and an IT system. And then additionally, and perhaps more importantly, it would avail Vermonters to a much greater inventory of medication, both in terms of type and quantity. So that's a high-level overview, and I'm happy to dig into any questions that you may have.
Great. So to be clear, we don't have this today in Vermont.
Correct.
Do you know if our surrounding states have it?
I believe most of them do. So nationally, there are about 40 states that have these programs authorized. Only about half of those states have implemented these programs, and then how they implement them really runs the gamut. Many states restrict participation to residents within the state, but there are a handful of states that don't do that.
New Hampshire does.
New Hampshire does.
New Hampshire does what?
Has one.
Has one.
But
Okay.
other states don't yet.
Okay.
Okay.
I saw the map, yeah.
Okay. Alan and then Art.
How many sites do you feel you need throughout the state?
It's a great question. So if this were to move forward and we were to contract with the program, there would be a dedicated outreach campaign. And really, I think the idea is to cast as wide a net as possible, working with as many facilities, and then to, a lesser extent, but an important one with individuals as well. So I think the more participation, the better. And I should note too, the idea here is that this would be free for all participants.
And so, I'm sorry, Art, go ahead.
I'm trying to figure out who do we pay for this program? Is that how that works? And do we ask a fee some sort of fee from the patient that gets the drugs?
Yeah, it's a great question. So the way that we envision the program working best is that it would be free for all participants. And that's based on consultations with the stakeholders who we've worked with. It's likely that we would come back with a request to have the legislature fund this program annually. And that would look like, based on our figures, around $300,000 a year. Again, keeping in mind that the benefit would be about 10 times that is the minimum on an annual basis is what we receive as projections.
Okay, when you say free to the person receiving the drug?
Correct. Yeah, and the institutions participating as well, and the physicians and the pharmacies who are participating.
Okay, and we're paying for the physicians to go through all this stuff.
Essentially paying for the third-party organization to manage this with their infrastructure, their pharmacists,
right,
their warehouse.
Okay, so we're contracting this out to somebody.
That's right, exactly.
And we're paying for that contract, and then okay.
And I should note, just because you mentioned the fee for services, at this point, we don't envision having anybody pay. In particular, the folks who are benefiting from this program. The idea is to address folks who can't access this medication for financial reasons. However, we don't want to restrict that option in statute, as it may be something that we would look at later through rulemaking. If, for example, there was a decrease or a lack of funding from the state, we wouldn't necessarily want the program to founder as a result of that.
Okay.
I'm just going to tell a personal story. So when my husband was going through cancer treatment, we had great insurance and we had the ability to pay for the medication that he needed. But he did receive several prescriptions for pain medication, which he did not use. And at one facility, we had to bring that home with us, at which time, what do you do with it? At another facility, they had a program like this that we were able to turn in that medication. And then that medication was used for people who could not afford to get the medicine to help them through their treatment. So I'm assuming is that kind of what we're talking about here?
Precisely, yeah, except, rather than being at an institutional level, it would be at the state level, although controlled substances would be restricted.
Okay.
That is a uniform restriction across the board, and I think that's based on federal restrictions that limit who can handle those substances.
I won't tell you where we were then.
Okay. It may not be an issue among institutions.
Right. Topper. And then
No, I forgot what I was going to say. Okay, now I got it. So you're talking about the distribution would be done like through the free clinics and council on aging and that kind of stuff?
Yeah, the idea would be that any pharmacy or provider could register for free with this unused drug repository administrator. And then a patient would visit their provider or a participating pharmacy and gain access that way.
Let me ask one other question. Is it, are the controlled substances, are they restricted from this program altogether?
Correct. Yeah, I think that federal law prohibits or has certain restrictions on who can kind of act as, who can receive controlled substances and then distribute them back out. And so that is one of the few things that is uniform across all these programs nationally, is that controlled substances are never allowed. But virtually every other substance, with the few things that might be under what are called REMS schedules, are at least on the table for consideration. And we would look at all of that during the rulemaking process as to what other drugs might potentially be restricted.
Yeah.
I think this is actually more of a question of curiosity than the policy. I think the policy is great, but how on earth does a pharmacist check every single pill, capsule for tampering? That must be a mass quantity.
Yeah. Well, so the two organizations that we spoke with that operate, one in Iowa and one in Georgia, they've got pretty substantial infrastructure in place. So big warehouse spaces, lots of pharmacists who look at this stuff. One of the typical restrictions that we would probably look at as well in rulemaking is that in most cases, the medications have to be in the manufacturer's sealed packaging. There are exceptions to that in certain facilities like hospital pharmacies that use bulk bottles, but are under stricter controls. But so I think I would leave it to the folks who manage those programs to get into the details more about how they do that. But I can tell you that they've been doing so successfully for years. Iowa's had their program up and running since 2007, distributed millions of dollars worth of medication over the years. So I'll leave it to the professionals to answer that more specifically, but they seem to be doing a pretty good job with it.
Just keep thinking about Tylenol.
Oh, yes. You
Yeah,
have to think about that, yeah.
right. Any other, Leslie?
Yeah, I just want to understand, and maybe when Jen does the walkthrough, I'll understand it better of sort of this process, because this is just to set up rulemaking.
Correct.
So it doesn't make a commitment to anything other than rulemaking and then what happens? So it goes to rulemaking and then what?
So would you like me to, yeah. So,
Yes, please.
yeah, right. We would go through the rulemaking process with public engagement and stakeholder engagement. And then we would be looking to contract with an entity, which would agree, of course, to abide by those regulations. And then we would implement the program likely after we were able to secure some funding for it. So I think the anticipation is at this point, if this was to move forward and pass this session, that we would be back during the adjustment session.
Budget adjustment.
Budget
To
adjustment, thank
fund
you.
it
Yeah.
then? Okay.
Everything would be repacked, I'm sure I should butt in.
Go ahead.
Everything shouldn't be repacked, would be repackaged, correct? I mean,
Correct. Yeah, all the patient's identifying information, everything is removed except for the expiration date and the name of the medication.
And that stuff would be held separately for those, like at a pharmacy, for those that can't pay, is that?
Yeah, it would be held in a central repository, and then folks would put in a request for that medication.
Oh,
It's
all
shipped
right,
to a
okay.
pharmacist or a provider where they can access the medicine there.
And would it be any medication or just the high end, like you
No.
must have had high end, medication? Would it be?
We also had, I'm sorry, we also had like bandages that weren't used, like that were still in the packaging. So I don't know if that would be part of it.
Yeah, that's something we would explore during rulemaking. There would need to be compelling reasons to restrict that medication if folks could make use of it, and it would, save it from being discarded. Other states, in some cases, for example, prohibit cancer medication. That's something that we are not likely to prohibit, given the expense of that.
Well, what I'm getting at is
Yeah, yeah.
there's some medications that are pretty cheap anyway. And
Sure.
this process might make them more costly for everybody. By the time you put it in the thing, take it, make sure it's safe, repackage it. Some of the medication could just get new and be better off, money-wise. I don't know.
Perhaps,
I
yeah.
don't know what level of medication you're talking.
Yeah, I mean, I think there's a clear imperative for the higher cost medications that are
Okay.
harder to
All right,
access.
that's,
But I don't think that we'd want to commit at this point to restricting lower cost medications too, if it could be cost effective and provide benefits for Vermonters. But again, we'll explore all of that during rulemaking and make sure that we get those parts right.
So there's something on the NCSL website that goes deep into it. It might be worth posting on our page, but what they're talking about is medication from long-term care facilities. A lot go unused because the patient condition improves, they change doses, change care settings, or in fact die. So there's this whole repository of medication that it could be hypertension or diabetes, but then can be redistributed to people. So I like the idea of it not going to landfill. And I think that's really an important piece of this. Yeah, and I have a couple more questions.
Go ahead.
Yeah. Well,
I was just going to say, it may also be worth noting that a lot of these medications are paid for with tax dollars. So, they're paid for by the VA, Medicare, corrections.
yeah.
So I think it's also an important point to take note of.
So it's a savings there as well. I was just sort of wondering what your prediction was when you would get the rules done.
I think that we would be able to hit the ground running and start on this, as soon as the bill passed. So later this summer, if
So yeah, by the summer.
yeah. And the rulemaking process, depending on engagement, the actual APA process takes, a minimum of 4 months typically. And we would probably plan for 2 months of engagement. So, we would 6 to 8 months.
What's APA process?
The Administrative Procedures Act.
Thank you.
Yeah. Just the actual formal rulemaking process from ICAR through LCAR.
Okay,
Yeah.
yeah. So that leads me to think about coming back with a status report to us, because if we're going to fund it, go to BAA,
Yeah,
then,
absolutely.
yeah, I would sort of,
Right, we would want to take.
I'd want to include that in the bill, somehow that we would get a status report when you were done with rulemaking or something along those lines before it went to BAA.
Yeah, that absolutely. We would be happy to do that.
Or if it went to be, if it was recommended to be in the BAA, we would take testimony on that, yes.
Yeah, so maybe that's the right process, rather than in the
That's
bill.
probably the right process to do it that way.
Yeah, I just didn't want it to get lost. I mean, I think about rulemaking as this giant black hole, but yeah.
Right, but if it's in the BAA, it comes back to the committee.
Yeah.
Yeah.
So it would have to come back to us for you to go forward, because you would, yeah.
In order for it to be implemented the way that we would envision it, again, there would be alternatives in terms of funding the program, but that was not in line, those would not be in line with what the stakeholders' consensus was.
I think rather than saying we would want a report,
Yeah.
I would be comfortable putting in something like we would want a presentation back in January. I'm trying,
Yeah.
like if we don't need a report, let's not do a report.
Yeah, I get it.
But let's make it clear that we
Your back.
want something, to remember, for us to remember too, we want to hear from the department on what happened in the present, like we are today.
Well, like with status, stakeholders, I'm not sure if you're here for this or, to.
I have one question.
Sure.
Are the pharmacists?
Yeah, absolutely. There was broad consensus from pharmaceutical manufacturers to long-term care facilities, BAS, VMS, OPR. So broad consensus on this, that in support of establishing this.
So we have Voz in the room by chance. Would you like to comment?
Sure. Devin Green, Vermont Association of Hospitals and Health Systems, also representing some of the Provider Association Coalition, including VMS, I'm sure I'm gonna forget some people, but definitely VMS and the Vermont Healthcare Association, and I think one more. But we support this bill. We think it's a win-win-win. The only addition we'd like to add is some liability protection. Because this lowers the barriers to people participating and will ensure that the program can sort of hit the ground running. Georgia and Iowa, which both have really successful programs, both have this liability protection in place. And it was recommended in the report done by VDH.
Okay, so it is in the report.
Yeah, and we are supporting that language as well.
Okay. So can you just notate that?
Yes, but we can't do it through rulemaking, so that makes it a little bit more complicated.
Okay. We'll talk about that when you come up. Okay. So since we're gonna have time, we're gonna have Jen walk through the bill, and if you can both stay at that point, we're gonna keep, I don't think we're done yet, but then we can talk about that. You have questions?
I've been listening when I wasn't in the room, and I heard one representative ask about the cost of the program, but that made me wonder, has any analysis been done on how much gets wasted now and how much that expenses, like how much the state spends on these drugs that then are not being used?
It's difficult to get estimates that are specific to Vermont. EPA did an analysis several years ago that looked at drug waste, and it was in the I think hundreds of tons of waste, or even significantly more than that. Billions of dollars nationally are wasted. I think just from long-term care facilities alone. So it's a significant number. We would anticipate millions of dollars worth of medication to be saved here in Vermont, and a value of, again, $3.5 to $7 million annually, just in the value of medication itself distributed back to Vermonters who need it.
And I heard correctly that people who receive these recycled, I don't know if that's the right word, but like it's not reused, redistributed medication, they don't pay an additional co-payment or like it's free.
That would be the objective here. There would have to be, the screening would be done for eligibility. The rulemaking would establish what the eligibility or prioritization requirements would be. And then, as envisioned now, at least, it's likely that either the provider or the pharmacist would do a screening. It would probably just take the form of a self-attestation that they have difficulty affording that medication or that they can't afford it. Right, the idea is that none of the participants in the program, the providers, the pharmacists, the patients, or the facilities who are donating that medication would pay a fee to do so.
Yeah, I guess the only thing I would be concerned about would be if we did this in a way where one individual is getting the medicine, not using it, and then the state takes it back, but then another individual gets it, but an insurance company is getting making them pay a copay for something, Because I feel like that's double billing on some level. So I just want to make sure however we do it, that it is really free for people.
Yeah, absolutely. And that would be our objective as well.
Someone, Art, and then
Yeah.
Alyssa, and then Leslie.
I had a question. Oh, I know what it is. Has there been any discussion, do we see this, and I don't know how, but there's probably a mechanism there, lowering drug prices for everyone at some point?
I think it's fair to say that there will be downward pressure on those costs. We didn't want to overstate the case, given Vermont's size and the scope of the program, that, 35,000 medications annually are going to have a significant impact on those costs. But I think it's fair to say that there will, of course, be cost savings within the healthcare system itself, because they're not going to need to pay for these drugs that otherwise would have to be paid for anew.
And potentially access, right? So some people may say, well, I can't afford the drug, so I'm not going to even try to seek it out. With this program, they would have access to something they wouldn't normally have access to.
Yeah.
Alyssa, and then Leslie.
So assuming that whatever eligibility to receive the drugs is probably going to be income-based?
That's correct. Yeah, the recommendations that we put forward in the report, I think, had 5 criteria. And we were careful to say prioritization because we don't want to, restrict access to the program if there are sufficient drugs to kind of go beyond these thresholds. But the prioritization would be under 400% of the federal poverty level, uninsured, underinsured, in the Medicare donut hole, or have high copays or high deductibles.
I was just thinking, ultimately, if we do it income-based, aren't we just saving Medicaid money?
Yes, I think that it's fair to say we'd be saving Medicaid and Medicare money. I think we just were careful not to overstate, what those savings would look like.
And so this is maybe getting into the weeds only because I'm dealing with this issue right now. So because the cost would be free, would that then be outside the realm of, if somebody is insured, would that take them out of the formularies? I know somebody I know was just prescribed 2 incredibly expensive drugs, which are not even in the realm of insurance saying we'll cover it.
Right.
If those were available, would they be available if you're no longer on your insurances, if you go off your insurance's formulary?
So, getting into the insurance piece gets a little bit outside of my wheelhouse, but I think the idea is that folks would access this medication. They would have to demonstrate a need for it. And my understanding is these programs, it would not involve insurance.
Thanks.
Leslie?
I just want to comment, there have actually been 2 reports. One was in 2018,
18,
and then one in the 23. The 23 updated the early, but it was a big work group evaluation of the process, and that might be, worth putting on our page. But involved, there were DIVA, UVM, Devin was on that group, Shayla and David Englander, Jill Olson, OPR. So a lot of people involved in looking at it more deeply, thinking that it was a good thing to do. So it's been on the table. I think COVID kind of diverted it, as always.
Yeah, and I'll note that Senate Health and Welfare asked us last year to provide this update to the report, which is why we did that.
Great. Right. Thank you very much.
Thank you.
Hang out for
Hang out here around the bench.
around the bench is great. We'll have Jen come up and do a walkthrough. So it is on our community page. Under Jen Carby. Page 414. That's the one we passed on. Think about it.
All right, are you gonna want me to put it on the screen?
That would be great,
Doing the Zoom?
if you don't mind.
Oh, that's all right. Just a moment to join the Zoom call.
Yeah.
Was a family.
Yeah. I think this is a great one.
Thank you, Claire. Just pull up the page again. All right. Okay, great. All right, well, good morning. Jen Carby, Legislative Counsel. So we are looking at H 414 as introduced. One of your committee members was a co-sponsor. And this is an act relating to establishing an unused drug repository for Vermont. And so it would, it would create a new subchapter in our existing chapter on prescription drug cost containment in Title 18. And this is the unused drug repository program. It would create this new section 18 VSA 4671 that would allow, not require, but allow the Agency of Human Services to contract or enter into agreements with qualified entities as needed to create and administer an unused drug repository program for the collection and distribution of unused drugs in Vermont. And then the next section is really just rulemaking, directing the agency to adopt rules for the administration of the program, including rules regarding, and then it's got some specific provisions. So donations to the program, which may include donations from institutional settings in Vermont, such as pharmacies, long-term care facilities, Veterans Administration facilities, correctional facilities, hospitals, and other facilities, as well as donations from individuals. Rules on what types of drugs can be donated to the program, safety criteria for donated drugs, which may include packaging requirements and inspections, and patient eligibility to receive drugs from the program with priority given to patients who meet one or more of the following criteria. Patients with household income below 400% of the federal poverty level, patients who are uninsured, patients who are underinsured, patients who are Medicare beneficiaries and are experiencing a coverage gap in their Medicare prescription drug coverage, that's the donut hole, and patients who are on a high deductible health plan or on a plan with high copayment requirements for prescription drugs, or both. And it would have the act take effect on July 1st. One thing I do want to mention at the outset, as he's not here to say it, but Nolan asked that there be specific language added that I think makes sense, saying something to the effect of, to the extent that funds are appropriated for this purpose, or something like that. So it's clear that it does require a funding source appropriation from the state in order to actually make this happen. But also does not obligate the state unless you have made that appropriation. I know there was mention of perhaps some sort of a report back or check back. I don't know if you want language or you just want that to be part, I mean, as I think Brendan said, it would need to be part of their budget request, either for budget adjustment or the FY25 budget. So that may be an opportunity, or you could specifically request it, or you could ask them to make it, do an update as part of their budget adjustment presentation. We've done that before as well.
I think that latter part, I think would be great.
Okay.
Again, I don't want a full report, but for everyone to be on notice that we're going to want to talk about.
Yeah.
Right.
All right, so we will make that as part of the FY24 budget adjustment presentation. And the other piece that was mentioned by Devin was the limitation on liability. And that piece I do think needs to be done statutorily as opposed to delegating rulemaking authority to the agency or to the department. That's a pretty big delegation of authority that I looked into and is not something we've done in the past. So there may be legal issues with doing it. So I think putting in some general language around immunity for providers and others, if that's what you're interested in doing, would be fine. And there can be more detail in the rulemaking.
And so would that fall here, or would that fall subsequently if through rulemaking and budget we decide to move forward with the program?
I think it would probably make sense to put it in from the outset.
Okay.
Especially, it sounds like, there may be some impact on the willingness of providers to participate if there is not that provision, so it may not make sense to set it up if
Okay.
they're not willing to provide that limitation.
So may I ask the three of you to work on language for tomorrow morning?
Great.
Okay, that would be fantastic. Brian?
So I have 3 questions just about the definition of the term, of some terms used, because there's no definition section.
Yeah, so hold on a sec, because I'm gonna take this down. I'm gonna pull up, because where this lives is in an existing chapter, so I just want to put
Where there
that.
is a definition.
Where there are definitions of a number of things, but if we're missing something that should be a defined term, so.
Well, at the very least, you can show us and on the record, we'll know what it means, so. thank you.
Exactly. All right.
So I figured this is a good time to ask before you do anything else.
Great time to ask.
So if I may comment?
Can we wait until?
I just wanted to say that the NCSL has protection from liability is guaranteed for both donors and recipients, so that's based in that too.
Great.
So that's kind of embedded there.
Ready?
I am ready.
So, I'm curious, what do we define as, and I'll read the 3 terms, high copay, high deductible, and underinsured?
None of those is defined here. I think high deductible health plan is, at least under federal law, fairly well established because there's a minimum deductible requirement to qualify for a health savings account that goes with a high deductible health plan.
So like would a bronze plan on the exchange with the highest deductible you can get through the exchange be considered a high deductible plan, or is it?
Anything that is described on the exchange as a high deductible health plan qualifies under.
I'll look it up.
I would see those kinds of terms likely being part of rulemaking, especially because this is really set up to send them to go do rulemaking. So that's something that would
That would be the intention.
So that would also mean then there'd be stakeholder input into defining what is meant by those terms.
Yeah. I mean, we'll see where it comes out. I just hope that we we have the broadest, how do I say, the lowest threshold and like the broadest point of access for people to get things versus like, and I think considering underinsured, like what that means, like that people can have insurance, but they're not using it.
Right.
That if we can encourage people to utilize this program, then in the long term, it saves cost on healthcare and it reduces human suffering. So I just wanted to, that's all.
Yeah, that's good points. Tupper?
So since it says one or more of the criteria, you don't have to be 400% of the federal poverty.
Right. So I mean, this is sort of setting out effectively setting out legislative intent for their rulemaking. So priority given to patients who meet one or more of those criteria, right? So you don't have to meet all of those. You can be over 400% of the federal poverty level, but underinsured.
Yeah.
Okay.
Yep.
I just want to understand the relationship to the BAA. So I understand that we, don't put any money in here, but you come back. Does that coming back to the BAA get into the bill or not? How does that get explained?
So I will put in a reference saying that a section saying something to the effect of the health department shall provide an update on its rulemaking process as part of its FY24 budget adjustment presentation.
Okay, thank you. That's all. Good.
And so I guess I just want to be clear that potentially all this rulemaking could happen. So let's say we pass this and it passes the body and is signed into law, the rulemaking could happen and we could still not fund it.
That's right.
So just want to be clear on that. Okay.
And this question is maybe for you, Lori, as well as for Jen. What's going to be the future of this bill? Are we trying to get this done by Friday?
If possible, without ensuring that we hear from everyone.
Okay.
Right, ensuring that we are all comfortable with a vote. Yes, my hope that we could get it out.
Okay, so, but this is the bill that we are thinking about voting on?
Yes, this is the bill with the amendments that, or with the adjustments that Jen has talked.
Okay, yep,
Yes.
thank you.
Yes, and then it would probably still go to appropriations.
It may,
It may
I think, the clarity of not obligating funds may not send it there, but the potential that funds will be requested may send it.
May send it there, right, so.
So I think that
I know how that will,
that'll be a question for the
yeah.
clerk and speaker.
For those in the room over there, do you know of any parties that are hopefully paying attention to us who would object to this?
Devon Green Vermont Association of Hospitals and Health Systems. This is the warmest and fuzziest issue that I've worked on. Everyone agrees. So I highly recommend supporting it. I can't think of any parties who would object to it.
Okay,
Neither.
okay,
Close to this idea.
okay. And I'm gonna look on the left side of the room as well.
Have we heard from large pharmaceutical companies how they feel about this, or insurance companies?
Were they part of the study at all?
We've heard from representatives of those companies, and they're supportive of this as well, with the caveats that the liability protection be conserved.
Because they want to be free from any liability of being reused
Correct.
or not redistributed, not reused, ew. Yeah.
We have to have a regurgitation.
I'm not the one who went there today.
If I could comment on that, on the original study, there was someone from CVS and also someone from DEVA Division of Pharmacy Services. And they did get it, they were involved in that.
Great, thank you. All right, any other questions for Ledge Council or for Department of Health or for Roz?
Warm and
Okay,
fuzzy is
so
good.
warm and fuzzy. So we will hope to have language quickly back at some point. And Claire, can you put this tomorrow on the agenda and a possible vote? Would be excellent. And with that, I think we can take a break. I feel like we're wasting time when we don't have time to waste.
We'll go talk about immunity.
Yes, you will go talk about language, and let's come back we're doing psych pack at 11, right? Sorry, I'm confused with my guests here.
That is what it says.
Yes. Let's come back a little bit before 11, we'll just take a long break.